Welcome everybody to our third gathering. Speaker tonight, Dr. Sven has kindly accepted to talk about the growth of the craniofacial skeleton, hopefully with a focus on airway development. And this is one of the special interests of Sven, who is from Adelaide. He graduated in 2012 and finished orthodontics in Canada about 4 years ago, correct?
Yeah, well I did my main training in Adelaide and then a fellowship in Canada. Yeah.
And he practices here in Unley, and so I send all my patients to Sven because he's got a
And he looks
focus
after
on
my
airway
daughter.
health. Yep.
Good. Yeah, so first of all, thanks to Dr. Roche for inviting me to speak tonight. I've enjoyed coming to these other sessions and listening to everyone else speak, so I was really happy when she asked me to speak about one of the topics that I'm really interested in. Happy to talk about. So I'll be speaking about the growth and development of the craniofacial skeleton and the effect of the breathing pattern, so whether it be oral or nasal breathing, on that jaw growth. And I'm lucky to work both in the public and private sector, so I work over in Unley Orthodontics, and I also tutor at university and work in the craniofacial unit at the Women's and Kids. So I see lots of kids with other craniofacial disorders and special needs, which keeps my week really interesting. So I thought I'd start off with a picture of this 17-year-old girl that I saw back in my training, and when I look at this, I really think that this is something that is entirely preventable. She was really a chronic mouth breather. She was never referred to any other specialist for any kind of airway assessment. She had a really narrow maxilla and open bite malocclusion, so that's where the front teeth don't meet together. And really crowded and protrusive teeth, and you can see that she had some chipping of her teeth. So I think it was really a failure of the healthcare system, because now this patient, she finished growing, and really probably the best treatment to get the most ideal outcome would be to have some kind of orthognathic jaw surgery. So really tonight I really want to just kind of focus on some of the early treatments that we can do, or I can do as an orthodontist, to hopefully prevent this kind of malocclusion or crookedness of the teeth to develop. So I'll talk a little bit about the growth and the development of the jaws and a theory called the functional matrix theory. The breathing mode on the growth, some of the related orthodontic problems, and some of the early orthodontic treatment that we can do to correct some of these issues. And I have a big focus on evidence-based treatment, and I'll touch on some of my kind of favourite articles tonight on this area. So yeah, this is just a funny little quote that I found, that the plural of anecdote is not data. So although there's not always evidence for what we do, we try and kind of base most of our things on that. So that's where we like to come from. So in terms of growth and development, it's really important to know what normal development is, so that we can look and we can see what abnormal or even pathological development is. And growth and development are not synonymous, whereas growth is really an increase in size, whereas development is really a change in the degree of organisation or complexity. And these growth charts are really simple and easy to use and easy to plot our patients on, just to see whether they're actually in that normal growth curve. And if they're outside of that curve or deviate from that curve, that's when we need to be a little bit worried and maybe investigate that a little bit further. So there's three main kind of growth theories. The first one is that bone is really the determinant of growth, and that it's really only genetics that plays a role, but that's been widely discounted. The other two theories is that cartilage is a primary determinant of skeletal growth, and that bone is secondary and passive. And probably where we're kind of heading, and where most of the research is going, is that the third theory, that the soft tissue matrix, so the muscles and the ligaments around the bone, really determines that growth, and that the bones and the cartilage are secondary to those functional needs of the muscles. So when we look at the growth, it's really an interplay between the environment and genetics. So genetics being that blueprint that really shows you how much growth we'll get, so the increase in the size of the jaws. Whereas environmental factors affect the development, so they can change the shape of the face or the development of the jaws. But they're not going to have a really big increase or big effect on the size of the jaws. So that picture on the left is really a classic example of a class 3 malocclusion. So he's got a really big lower jaw or mandible. And that's an inherited trait from, I think, for this patient, it was his father's side. So that's something that is a genetic predetermined length of that mandible that we, as an orthodontist, is really difficult to stop or even slow down that growth, because that's something that is genetically determined. Whereas the patient on the right, this is a classic kind of environmental malocclusion. You can see she's got that really long, narrow face. The lips are struggling to get together, really thin nostrils. And she's got those dark kind of rings under her eyes. So that's the kind of a classic mouth breathing patient that we see. So the functional matrix theory was developed by a guy called Melvin Moss in the 60s. And he wrote that the major determinant of the growth of the maxilla and the mandible is the enlargement of the nasal and oral cavities, which grow in response to the functional needs. So that's looking at the function of the jaw muscles, the tongue, pushing out and really having an effect on the growth of the jaws. And the classic example of this is the growth of the cranium or the growth of the skull. It's really in response to the growth and the increase in the size of the brain. The growth of the head doesn't just grow and the brain doesn't just fill that space. It's really that pushing out pressure of that brain that pushes on those bones that increases the size. And another good example is if a child loses their eye as they're growing, if they don't have that pressure from that increase in size of the eye, then you get a smaller eye socket and you get the asymmetry developing. So it's really important that those organs such as an eye or a brain or a tongue is pushing out and creating those forces, and that's what really affects the shape and the size of the bones essentially housing them. So what about the mode of breathing and how does that affect the growth of the jaws? So there's some really good experiments by Harvard in the 80s, and they looked at some rhesus monkeys, and they were only 3 years old, and that's kind of when they're going to that really accelerated growth period. So what they did, they blocked the nostrils, and it sounds really horrible, and these studies would never be done but they blocked the nostrils of 8 of them so that they could only breathe through their mouth, and they looked and monitored them for 3 years with serial x-rays, so x-rays of the sides of their heads, and they looked at the development and how the jaws grow. And they saw that they had steeper mandibular plane angles, so that's the angle of the lower jaw. And they had an increased face height, so longer faces. And that was a result of induced neuromuscular balance between the neck and the facial muscles. And this is a classic kind of example, going back to this patient. You can see that she's got a really steep mandibular plane angle. She's got a long lower third of her face, really narrow nares, and those potentially incompetent lips. And when we look in the mouth, you can see the classic kind of narrowing of those arches, really constricted, and some associated anterior and kind of posterior crookedness or crowding of the teeth. So when we think about mouth breathers, the blockage of the airway can be in kind of one of 4 spots or a combination of them. It can either be at the nose or the maxillary base, up in the turbinates if they're in large turbinates, back a little bit further back around the adenoids or a little bit further down around the tonsils. As an orthodontist, I can really only have a small kind of effect on the nose or the maxillary base. And that's why it's really important that for most of my patients, if I see any airway issues, then I'm going to refer to an ENT for an airway assessment. And really the reason, the research behind this is that the growth or the development of the mandible can be greatly affected just by increasing those airways. So this is a study back in the 80s again from a guy called Linda Aronson in Scandinavia. And they looked at 81 children who had their adenoids removed because they had severe nasal airway obstruction. And just after doing that, no other kind of orthodontic treatment or expansion or anything, 48% of them changed just from a mouth to mainly noise breathing. And obviously the airway increased, and they had significantly less vertical growth and an increased projection of the mandible, because if we're breathing through the nose mainly, or we're breathing through the mouth, then we get more kind of downward and backward growth of the mandible. Whereas if we're breathing through the nose, then we get more forward and upward growth. I hope that makes sense. So even though these patients might have an airway assessment, they might have their tonsils or adenoids removed, a lot of them still need some orthodontic expansion or some kind of treatment. And there's 4 kind of main ways that we can do this. The most typical that I use is a rapid maxillary expander. Sometimes it's called a Hyrax or a Haas expander. But there's other options that we can use, and that's a transpalatal arch in the upper left. Another favourite of a lot of orthodontists is a quad helix, because essentially with a rapid maxillary expander you need the patient to turn the screw each day or twice a day. Whereas a quad helix, you can activate that and then you can just let it go and it slowly expands the maxilla. The other way is using orthodontic forces from arch wires or aligners.
And what about the tags on the other side of the implant passage?
Oh, I'll get to that. You're skipping ahead. That's alright, I'll touch on that. So really the treatment timing for any kind of expansion is really the key, and this is a good study from Becchetti out of Italy. Although it's a little bit old now, it was a really good study because they looked at 21 prepubescent and 21 postpubescent patients, and they also had 20 untreated controls so that they could compare to that. So they used a Haas expander, which is just basically a rapid maxillary expander with a little jack screw in it, like shown there. And the key to this study is that they took measurements before they did the expansion, after they did the expansion, and they also had a long-term follow-up up to 5 years. So they found that there was adequate expansion in both of the groups, and they achieved their kind of orthodontic results. But the prepubescent group had significantly greater short-term increases. But the most important was that in the long term, the maxillary skeletal width, the intermolar width, the latronasal width, so the airway width, and the lateroorbitale, so they're actually looking up around the eyes, they were all significantly greater in the treatment, in the group that was treated earlier. And that's really key. And there's a good reason for that, which brings me to my next slide. And this is a study done in the 70s on a whole lot of human autopsy material. So quite a few boys and girls aged from 0 to 18. And this lady, Berta Melson, she took surgical slices through the maxilla, so that's across the side like that, and she looked at the suture that goes through the maxilla and how that changes as we age. So up in here you can see this is a patient who is only 1 year of age, and you can see the suture is pretty much broad and is flat and Y-shaped. By the age of 10 it's starting to get a little bit more complex, a little bit more interdigitated. But as soon as we hit puberty, or get a little bit possibly past puberty, it gets much more interdigitated, much more complex. It never actually fuses, so the bones never actually fuse, but they get so tortuous that it becomes much harder to expand that maxilla. That's why we saw in the other studies that you get a much better result in terms of expansion, and much better long-term results if we're doing that earlier, before puberty essentially. So what about adults? Can we do much expansion for those patients? So more recently, more and more adults are having clear aligner therapy, such as Invisalign, and that's these little plastic trays that you change weekly, and that slowly sequentially moves the teeth into position. And this is a patient that, hopefully this plays. It is, yeah. So over 43 weeks, we were able to slowly widen and slowly expand those teeth. And a lot of that movement was just the teeth tipping out, but some of that was actually bodily expansion of those teeth. So we really went from someone who was really narrow and had a bilateral posterior crossbite to getting that really nice maxillary width there. And this is backed up with some really quite recent research out of Italy, who found that in all kind of adult subjects, they all had significant differences in terms of expansion. And this is all with aligner, clear aligner treatment, such as Invisalign. But the key out of this study, and you hear that a lot from a lot of orthodontists, is whenever we're doing any kind of Invisalign treatment, we always have to overexpand or overdo the treatments because we know that things will come back a little bit at the end, or it might not fully express. Probably why this case works so well is that you can see on that top left picture the upper teeth are actually leaning in a fair bit as well. So a lot of that expansion was that the teeth were just upright or brought out or tipped out a little bit. So kind of case selection works in our favour as well. In terms of braces, this is a study done in 2008, and they compared a traditional kind of rapid maxillary expander, so that's one with a little jack screw, compared to Damon braces. And they found that they got pretty similar results either way, but they noticed that the expander group had about 2 millimeters of actual maxillary base expansion, so skeletal expansion, whereas braces only had about 0.6. So if we want to get any kind of skeletal changes, we actually do need to use that rapid maxillary expander to do that. As Rose kind of touched on, more recently, more and more people, especially in Japan and North America, and now in Europe, are using TAD-borne expanders. And a TAD is essentially a temporary anchorage device. So it's a little titanium mini screw, like we can see, which is placed in the bone, and it's only temporary. Sorry?
Doesn't look all that little to me.
No, yeah. They range from about 7 to 9 millimeters and about 2 millimeters in diameter. So we call them mini. I think it's probably to make us feel better when we put them in. Yeah, compared to normal dental implants. Yeah, that's right. So essentially, we're either placing 2 or even 4 of these in the palate and attaching it to an expander. And these CT images, this is an adult patient, and you can see that although that suture was probably so interdigitated, we're still able to actually break that suture open. Probably there's probably lack of long-term research for this. It's probably only been around for about 5 years, so it'd be interesting to see how well these kind of cases do long-term. But the results are really interesting. This is a study just done only last year, and this is what those expanders look like. So those are the full kind of TADs placed, and a lot of people will also put metal bands on the molars to support the teeth at the same time. Although you don't even need these bands, you can just put this device in without the bands. But this study compared non-growing patients to adult, growing to adult non-growing. And they found that although they got the same amount of expansion, there was about 2 millimeters more in the growing group, and that growing group essentially, I guess their bones are more kind of plastic and are able to get better results. So I guess I'm more leaning towards earlier is definitely better, even when we're using these TAD-borne expanders. The other way to do expansion in non-growing patients is a surgically assisted expander, and this is something that I would personally do as a kind of a last resort because there are lots of risks involved with this. or the risk of the surgery.
Oh, sorry.
That's all right. And the other main risk, if these cuts are placed too low in the maxilla, there's a risk that you can devitalise, or some of the teeth could potentially die. And I've seen a few cases where that has happened. So
That's
try to
not the,
avoid
is that
that.
a dome technique? No.
No, this is like a SAMI, so it's essentially it's a general anaesthetic procedure done by an oral and maxillofacial surgeon, and they make all the Lafort 1 cuts,
Right.
and they also have to do a down fracture, so they
what's
can
the
actually
difference
loosen that up.
with the dome? Dome doesn't have the mid-palatine cut, correct?
That's correct, yeah. Yeah, but
They
it's
use the TADs instead.
yeah, that's right.
Ah, okay.
But this is pretty intense. This procedure.
No, no.
Yeah,
I
that's
don't
right.
want them. We'll prevent them.
So yeah, I guess I'm really passionate about early intervention orthodontics because I think, or another term for that is preventative orthodontics, because if we can get in there at the right time, hopefully we can either prevent the need for further treatment in the future, or even make it a little bit less complex. And this is a good example of that. This is a little, I think she was 9 or 10 years old, and she had that classic narrow dental arch, anterior crowding, a few airway issues, and just after 6 months of some expansion and a few little braces on her top front teeth, we're able to achieve a really nice result. And it's not long, complex treatment. We usually try and make it quick, easy treatment, just so that these kids don't get burnt out.
A question. My